Welcome back to the Deep Dive. Today, we're really going deep, truly deep, into one of the most complex and specialized areas in all of medicine, organ transplantation.
It really is a peak of clinical practice.
Our mission today is to properly unpack the history, the, frankly, staggering logistics, and critically, those highly technical perioperative considerations, the anesthetic side of things. We want to get to a mastery-level understanding here.
And it demands that level. You need simultaneous mastery across, well, everything. Surgery, immunology, pharmacology, and absolutely anesthetic management. What was just theory a century back is now this incredibly structured, intense process that saves lives.
Okay, let's unpack this. The evolution of transplantation and the profound, staggering disconnect between need and supply. It's quite sobering when you look at the numbers.
It really is.
So around 80 people get transplants every day in the U.S. Sounds like a lot, right? A huge success.
On the surface, yes.
But the flip side is that 20 people are still dying every single day, just waiting for that call.
That gap, that disparity, is the harsh reality this field operates within. You look at 2019 data, we did nearly 40,000 transplants. Fantastic number, real progress.
Right.
But there were still over 112,500 patients on the national waiting list. That's managed by UNOS, the United Network for Organ Sharing.
And the bottleneck is biological, really.
It's brutal. The estimate is only about 3 out of every 1,000 people will die in circumstances that actually allow for organ donation. That scarcity just dictates everything, every clinical choice, every logistical move, every ethical discussion. It hangs over everything.
Given that pressure, understanding the breakthroughs that made this even possible is, well, essential. We have to start with the pioneers who solved the basic mechanical problems first. The actual plumbing, if you will.
Absolutely. You have to begin with Alexis Carrel. He's rightly called the father of transplant vascular surgery.
Right, the Nobel Prize winner.
Yeah. 1912 Nobel Prize for Medicine. He developed the techniques for vascular anastomosis, that surgical joining of blood vessels. He used incredibly fine needles, fine thread. Without his precise work, just hooking up the arteries and veins wouldn't have been feasible.
So he figured out the connections.
A lot of his principles are still fundamental to vascular surgery today. It was foundational.
But once the pipes were connected, the body fought back fiercely.
Yeah.
Early attempts just failed.
Universally rejected, exactly. And that's where the immunology piece comes in. Peter Medawar. He established that graft rejection wasn't a surgical failure, it was biological.
The immune system seeing it as foreign.
Precisely. An immunologic incompatibility. He really laid the theoretical groundwork for immunosuppression, which also won him a Nobel Prize. He showed the immune system treats that new organ like an invader. Needs to be destroyed.
So the challenge shifted, didn't it? From finding a perfect match, which is almost impossible, to finding a way to kind of dampen that immune response.
Yeah.
To apply the brakes.
Finding the right break, exactly. And a really effective break arrived in 1974, cyclosporine, introduced by Burrell and his colleagues.
Still used today, right?
Absolutely. It was a monumental step in pharmacology. It's a calcineurin inhibitor, targets T cells specifically, suppresses that rejection response. Cyclosporine and the drugs that followed it are still the cornerstone of immunosuppression protocols. They made long-term graft survival actually possible.
Okay, so these historical pillars, the surgery, the immunology, the pharmacology, set the stage. Now, let's talk about where the organs actually come from today, given that shortage. The main types of donation.
Right. There are basically 3 main avenues. The traditional method, the gold standard really, is donation after brain death or DBD.
That's when the brain has irreversibly stopped functioning, lack of blood flow, lack of oxygen.
Correct. But the body's functions, circulation, breathing, are maintained on life support. This gives the teams time for evaluation, matching, and then procurement. It's the most common pathway.
But not the only one anymore.
No. To try and bridge that supply gap, we're seeing more donation after cardiac death, DCD. Here, organ procurement happens after the heart has permanently stopped beating, based on very specific criteria.
And the sources mention this is becoming more prevalent, but it carries some ethical complexities. Because it involves coordinating the withdrawal of life support.
It does. It requires incredibly careful planning, very specific criteria, and strict protocols to ensure everything is handled ethically and appropriately. It's definitely more complex logistically and ethically than DBD.
And the third source.
The third source, which often yields the best long-term results for the recipient, is living donor transplants.
Usually kidneys or part of liver?
Typically, yes. From a family member, sometimes a friend, or even an altruistic stranger. The data showed nearly 7,400 of these in 2019.
And the big advantage there is control, I imagine.
Huge advantage. The surgery is scheduled, it's elective. This means the cold ischemia time, the time the organ is without blood supply outside the body, is incredibly short, sometimes almost zero.
Yeah.
And that dramatically improves how well the organ functions right away.
Okay, so we have these sources, but with over 100,000 people waiting, how is it decided who gets an organ? The allocation process. UNOS runs this.
Yes, UNOS maintains the national list with extremely rigorous organ allocation criteria. It's designed to be as fair and medically sound as possible.
What are the key factors they weigh?
It's a complex mix. Things like ABO blood type compatibility, tissue matching, HLA matching to reduce rejection risk. Organ size is critical, especially for kids or, say, lung recipients.
Makes sense.
Then there's medical urgency. How sick is the patient? This is often measured by specific scores, like the MELI score for liver or the LAS score for lungs, which we'll get into. Time weighted on the list still plays a role. And finally, geography matters.
Proximity.
Yeah. Closer donor and recipient means faster retrieval, faster implantation, less cold ischemia time, better outcomes. It's all balanced to maximize survival and equity.
Right. Let's shift gears now and dive into the most common procedure. Renal transplantation. Kidney transplant. The first successful one was way back, 1954.
Identical twins, a living donor, a landmark moment.
But for the anesthetic team today, managing a patient with end-stage renal disease, or ESRD, coming for transplant, that seems like one of the most physiologically demanding situations imaginable.
It requires total systemic awareness. ESRD means the kidney function, measured by glomerular filtration rate, or GFR, has dropped below 10% of normal.
Basically, the kidneys have failed.
Essentially, yes. And once that GFR dips below 15%, the patient needs chronic renal replacement therapy dialysis just to stay alive. Dialysis has to do the jobs the kidneys can't anymore.
Like what, specifically?
Managing fluid balance, getting rid of toxic nitrogen waste products, maintaining the body's pH balance, and even producing hormones like erythropoietin, which stimulates red blood cell production.
And it's striking that the main drivers pushing people towards ESRD are huge public health issues.
Absolutely. Today, the two biggest culprits sending patients to the kidney transplant list are uncontrolled hypertension and diabetes.
So the disease itself is systemic.
And the consequences of ESRD are profound, system-wide. It hits the cardiovascular system hard, the brain, peripheral nerves, the gut, the blood. Pretty much everything is affected.
Okay, imagine a patient. They've waited, on average, over 3 years. They finally get the call. They arrive at the hospital. What are the absolute top preoperative priorities for the anesthesia team thinking about heart risk first?
We basically assume they have critical cardiovascular disease until proven otherwise. Ischemic heart disease is incredibly common and often silent, especially in diabetics.
Why silent?
Autonomic neuropathy. The nerve damage from diabetes can blunt or eliminate the typical chest pain, the angina that signals heart trouble. Congestive heart failure is also common, maybe in 25% of chronic kidney disease patients.
So you have to actively look for heart problems.
Mandatory pre-op cardiac optimization. That usually means a stress echo, maybe even coronary angiography for high-risk individuals to check for underlying blockages before we put them through the massive stress of surgery.
And their blood. You mentioned it's affected too. Sounds like a chemical and mechanical mess.
It is in several ways. Two main hematologic issues. First, chronic anemia is the norm. Hemoglobin levels down around 5 to 8 GDL are common.
Why so low?
Because the failing kidneys don't produce enough erythropoietin. Second, they have coagulopathies, bleeding problems. Not usually from lack of clotting factors, but because their platelets don't stick together properly. Uremia affects platelet function.
So increased bleeding risk during surgery.
Potentially, yes. We might need to pre-treat with DDAVP, desmopressin, or even cryoprecipitate if the risk seems high or if they are actively bleeding.
Okay, let's talk about the really acute dangers. The electrolyte hazards. This seems critical.
Top of the list, most immediate, most lethal. Hyperkalemia, high potassium.
Because the kidneys can't excrete it.
Exactly, and high potassium can trigger deadly heart rhythm disturbances, or arrhythmias. While we might accept a potassium level of, say, 5.0 to 5.5 millieql in these chronic patients, anything higher needs immediate action.
What kind of action?
Calcium first, to stabilize the heart muscle membrane, then things to actually lower the potassium, like insulin and glucose, or ultimately dialysis. Preoperative dialysis is absolutely crucial for managing potassium.
You mentioned a tightrope.
Right. Dialysis fixes the potassium, but it pulls off fluid. So the patient might come to the OR with normal potassium but be significantly volume depleted, hypovolemic, which makes managing their blood pressure during induction really challenging. It's a constant balancing act.
So they arrive dialyzed, maybe dry,
Mhm.
a tough starting point. What other electrolyte issues?
Chronic hyperphosphatemia, high phosphate, is common because the kidney can't excrete it and also can't activate vitamin D properly. This high phosphate drives down calcium levels, leading to hypocalcemia.
And that has knock-on effects.
Yes, it leads to secondary hyperparathyroidism, which tries to correct the calcium but pulls it from the bones. This causes renal osteodystrophy, weak bones. Clinically, that means a high risk of pathologic fractures. We have to be incredibly careful just positioning them on the operating table. Gentle handling is key.
Okay, let's move into the OR, intraoperative anesthetic management. Where does the new kidney actually go?
It's usually placed in the right or left iliac fossa, outside the main abdominal cavity extraperitoneally. The new renal artery and vein are connected to the patient's external iliac artery and vein, and the new ureter is plumbed into the bladder.
Airway management straightforward or tricky?
Requires vigilance. General anesthesia with an endotracheal tube is standard. But because gastroparesis-delayed stomach emptying is so common, especially with diabetic ESRD patients,
Risk of aspiration.
high risk. So a rapid sequence induction, RSI, is strongly recommended to protect the airway.
Now, the choice of neuromuscular blockers, the muscle relaxants. This seems like a real test of knowledge for the anesthesia provider in this setting. What's the guiding principle?
It's all about how the drug gets eliminated from the body. You absolutely must avoid drugs that rely heavily on the kidneys for clearance. Their effects will be massively prolonged, unpredictable.
So succinylcholine, often used for RSI.
Use with extreme caution. It's contraindicated if the patient is already hyperkalemic because succinylcholine itself causes a small transient release of potassium from muscles. In a patient with high potassium already, that little bit extra could trigger a fatal arrhythmia.
Okay, so if potassium is high, or maybe even borderline, sucks is out for RSI. What about rocuronium? It's common for RSI too.
Rocuronium is a much safer choice in hyperkalemia because it doesn't affect potassium, and its primary elimination route is biliary through the liver and bile, not renal, so it's acceptable.
Not perfect.
Not perfect. Even its clearance is somewhat delayed in severe renal failure, so you still need careful monitoring with a nerve stimulator. But it's far preferable to drugs like vecuronium, which really depend on the kidneys.
Which leads to the preferred agent.
The muscle relaxant of choice, really, in ESRD is cisatracurium.
Why is cisatracurium?
Because it's metabolized by something called Hoffman elimination. This is a spontaneous chemical breakdown in the blood dependent only on body temperature and pH. It doesn't need the kidneys or the liver.
So its duration is predictable regardless of organ function.
Exactly. That reliability is gold in this situation.
What about reversing the blockade? Succinylcholine is common for reversing rocuronium now. Any issues there?
Yes, there's a significant consideration. Sugammadex itself is cleared by the kidneys. So in severe renal impairment, its clearance is significantly delayed. It hangs around much longer.
Does that mean you can't use it, or just use it cautiously?
It's still under investigation, but generally used with extreme caution and reliance on objective neuromuscular monitoring like a train of 4 ratio to confirm full recovery. Often, with careful dosing of rocuronium or using cisatracurium, the need for intense reversal is less critical. You might just let it wear off if the case allows.
Okay, fluids. You mentioned the patient might arrive dry. How do you manage fluids intraoperatively?
Yeah.
Very specific choices needed, I gather.
Absolutely critical. You must strictly avoid lactated Ringer's solution.
Because of the lactate?
No, because of the potassium.
Yeah.
LR contains potassium, about 4 millicu per liter. We're trying to keep potassium down. So plasmolite or normal saline are the preferred crystalloids.
Any downsides to normal saline?
Yes. Giving large volumes of normal saline can cause a hyperchloremic metabolic acidosis. Too much chloride leads to acidosis. And acidosis itself can actually drive potassium out of cells and into the blood, making hyperkalemia worse. So judicious use is key. We often use 5% albumin as well to help maintain intravascular volume without overloading with chloride or potassium.
Pain management, another minefield.
Definitely. Certain opioids are absolutely contraindicated or require extreme caution due to metabolite accumulation.
Which ones?
Meperidine or Demerol is a definite no-go. Its metabolite, normeperidine, builds up in renal failure and is a potent CNS excitant. It can cause tremors, agitation, even seizures.
Okay, avoid meperidine. What about morphine?
Use morphine with extreme caution. Its active metabolite, morphine 6-glucuronide, or M6G, is cleared by the kidneys. If it accumulates, you get profoundly prolonged sedation and respiratory depression, hours, even days later.
So what can you use safely for pain?
We tend to rely on short-acting synthetic opioids like fentanyl or hydromorphone, used carefully and titrated to effect. Multimodal approaches are key, using non-renal agents like intravenous acetaminophen, maybe ketamine in small doses, regional blocks where appropriate, anything to minimize the reliance on opioids with dangerous metabolites.
Okay, the surgery proceeds, the connections are made, the vascular clamps come off, blood flows into the new kidney. What's the immediate goal then?
Immediate function. This is the goal-directed therapy phase. We want that new kidney to start making urine right away. The focus shifts entirely to maximizing renal blood flow and output.
How do you encourage that?
Often involves a combination of strategies, maybe low-dose dopamine, dobutamine, or phenoldiazepam infusions, which are thought to selectively increase renal blood flow. Diuretics are common, an osmotic diuretic like mannitol, followed by a loop diuretic like Lasix or furosemide.
The idea is to flush it out.
Exactly. Flush the kidney, help clear out any ischemic byproducts, minimize the risk of acute tubular necrosis, ATN, from the transplant process, and hopefully see good, immediate urine production, which is a great sign of graft viability.
Okay, fascinating. Let's pivot now from kidneys to the pancreas, managing chronic blood sugar failure. Pancreas transplantation seems radical, offering a built-in insulin source.
It's the definitive treatment for type 1 diabetes, where the body's own islet cells are destroyed. It's also sometimes an option for very severe type 2 diabetics, those with profound insulin resistance where external insulin just isn't enough.
And these patients, like the kidney patients, arrive with significant systemic damage from their underlying disease.
Absolutely. Chronic high blood sugar from diabetes wreaks havoc everywhere. Widespread atherosclerosis, damage to both large and small blood vessels, macro and microvascular disease, and profound neuropathies.
Like the silent ischemia we talked about with the heart.
Exactly. And also things like severe gastroparesis, which complicates anesthesia induction, as we discussed. The multi-system impact of diabetes is immense.
Which type of pancreas transplant works best? Are there different approaches?
Yes, there are three main types: pancreas transplant alone, PTA, simultaneous pancreas and kidney transplant, SPK, and pancreas after kidney transplant.
And the outcomes?
The sources clearly state that the SPK, the simultaneous pancreas and kidney transplant, has the highest 5-year patient survival rate, around 93%.
Why is the combined approach so successful?
Part of it is likely that the kidney acts as an early warning system. Kidney rejection is often easier to detect clinically than pancreas rejection. So if the kidney shows signs of rejection, you can treat it aggressively, potentially saving both organs. The kidney sort of shields the pancreas immunologically.
That makes sense. So SBK patients are getting 2 organs transplanted. The pancreas itself is tricky surgically, right? It has digestive enzymes too.
It's a complex operation. You transplant the endocrine part, the insulin-producing islets, but also have to manage the exocrine part, the digestive enzymes. And the pancreas is known to be quite immunogenic. It triggers a strong rejection response.
Which means more immunosuppression.
Yes. Pancreas recipients typically need higher levels of immunosuppression, often starting with potent drugs that deplete T cells, like anti-thymocyte globulin.
And intraoperatively, managing blood sugar must be incredibly intense. Intraoperative glycemic control.
Non-negotiable. Glucose monitoring is constant, hourly at a minimum, but during the critical reperfusion phase, when blood flow is restored to the new pancreas, you're checking it every 15 to 30 minutes.
Why this sudden intensity right at reperfusion?
Because the moment that new, healthy pancreas gets blood flow, it starts working. It can release a significant bolus of insulin into the patient's system.
Potentially causing hypoglycemia, low blood sugar.
Exactly, sometimes quite dramatically.
Yeah.
So the goal is tight control. You want to keep blood glucose ideally between, say, 120 and 150 milli-GDL, and definitely under 200.
Why is that tight control so important right then?
2 main reasons. First, you need to protect those newly transplanted beta cells. Letting the sugar run too high stresses them out. Second, you need to prevent complications. Even with a new pancreas, if insulin release isn't perfectly matched initially, the patient could still potentially develop diabetic ketoacidosis, or DKA. So vigilance is key.
Okay, shifting again to the rarest, but perhaps most devastating type of organ failure addressed by transplant, intestinal transplantation. Who needs this?
This is really reserved for patients with intestinal failure who have exhausted all other options. They've failed maximal medical therapy, including total parenteral nutrition, or TPN.
TPN being intravenous feeding.
Right. They simply cannot absorb nutrients through their gut anymore. The most common reason is short bowel syndrome, SBS.
What causes SBS?
In children, it might be congenital conditions like gastrosphesis, or problems like volvulus, twisting of the bowel, or necrotizing enterocolitis. In adults, common causes are massive bowel resection due to ischemia, complications of Crohn's disease, or trauma.
And you mentioned TPN itself carries risks long term.
A major risk. Long-term TPN can be incredibly toxic to the liver. It often leads to TPN-associated cholestasis and eventually progresses to end-stage liver disease, ESLD.
So if the liver has failed too,
Then the patient needs a combined intestine liver transplantation. This is an exponentially more complex and higher risk procedure.
what are the big anesthetic worries during an intestinal transplant?
Massive fluid shifts are a huge concern. And related to that, the risk of graft edema. The newly transplanted bowel is very prone to swelling up dramatically.
And if it swells too much inside the abdomen?
That can lead rapidly to abdominal compartment syndrome. The pressure inside the abdomen gets dangerously high, compromises blood flow to other organs, makes ventilation difficult. It's a surgical emergency requiring immediate reopening of the abdomen. Constant vigilance for this is needed.
Wow. Okay, let's tackle the liver. You mentioned liver transplantation. Unique organ, unique challenges.
Absolutely unique. The liver has that incredible ability to regenerate, which is what allows living donor transplants. You can safely take up to 70% from a healthy donor. But when the liver fails comprehensively, it creates this systemic, chaos, both chemical and hemodynamic. It's arguably the most challenging transplant from an anesthetic standpoint.
And what's fascinating here is how the hyperdynamic circulation associated with ESLD can actually mask underlying cardiac dysfunction. It's a bit counterintuitive.
It is completely counterintuitive. The patient looks like their circulation is supercharged, but their heart might be quite weak underneath. Liver transplantation is the only definitive cure for acute liver failure and chronic end-stage liver disease.
How are patients prioritized for such a scarce resource?
Prioritization is primarily driven by the MELD score, the model for end-stage liver disease.
We mentioned scores earlier. How does MELD work?
It's a validated mathematical formula. It uses just 3 simple standard lab values: serum bilirubin, serum creatinine, and the INR, International Normalized Ratio, a measure of blood clotting.
And it protects.
It predicts the patient's expected 3-month mortality risk without a transplant. A higher MELD score means higher risk, greater urgency. For example, a MELD score over 40 basically indicates a near 100% chance of dying in the hospital without a transplant. That patient goes to the top of the list.
But I remember reading about MELD exceptions. Why have exceptions if the score is so good?
Because the 3 core lab values, while powerful, don't capture every single factor that drastically impacts short-term survival. Exceptions exist to give extra points for specific conditions not reflected in the numbers.
Like what?
Key examples include hepatocellular carcinoma, liver cancer, or HCC. Even with relatively good liver function labs, a tumor might be growing rapidly, justifying higher priority. Or specific syndromes like hepatorenal syndrome, HRS, or portopulmonary hypertension, PPH, which carry very high short-term mortality risks even if the main MELD components aren't sky-high.
Okay, let's dissect that pathophysiology of ESLD. You called it the hyperdynamic state. Why is everything running so fast?
It's driven by profound vasodilation, especially in the splanchnic circulation, the gut. The failing liver can't break down circulating vasodilator substances, particularly nitric oxide. This causes systemic vascular resistance, SVR, to plummet.
So the blood vessels are wide open.
Extremely dilated. To maintain blood pressure, the heart compensates by dramatically increasing cardiac output, CO. So you get high CO, low SVR, and usually high resting heart rate.
And this is where the masking happens.
Exactly. This state of low afterload makes the heart's job seem easy. It can hide underlying weakness, a condition we call cirrhotic cardiomyopathy. These hearts often have impaired diastolic function, can't relax properly, and sometimes systolic dysfunction too. They have a compromised ability to respond to stress.
Which surgery definitely provides.
Absolutely. The stress of anesthesia and surgery can unmask this weakness, leading to heart failure. We also see other major systemic failures linked to ESLD.
like the pulmonary system.
Yes, portopulmonary hypertension, PPH. This is pulmonary hypertension high pressures in the lung arteries, defined as a mean pulmonary artery pressure over 25 millimeter Hg, occurring specifically in patients with portal hypertension, high pressure in the liver's blood supply. Severe untreated PPH is an absolute contraindication to liver transplant. The right heart simply cannot handle the stress after transplant.
And the kidneys often fail too.
Very common. Hepatorenal syndrome, HRS. This is a functional kidney failure. The kidneys themselves might be structurally okay, but they shut down due to the severe circulatory disturbances and vasodilation caused by liver failure. It's essentially a severe form of pre-renal failure, defined by a rising serum creatinine, typically above 1.5 mg/dL. Type IHRS is particularly bad, progresses rapidly, median survival is just 2 weeks without transplant.
And the brain is affected, hepatic encephalopathy.
Yes. This results from the buildup of toxins in the blood that the failing liver can no longer clear, primarily ammonia.
Ammonia affects brain function.
It interferes with neurotransmission. The symptoms range from subtle things like changes in personality or difficulty with coordination, apraxia, all the way to deep coma. Management involves reducing ammonia production in the gut, using things like non-absorbable sugars, lactulose, and specific antibiotics like rifaximin or metronidazole.
Okay, the surgery itself. Orthotopic liver transplant, or OLT. It's famously broken down into 3 distinct phases, each with its own monster anesthetic challenges. Let's walk through them. Phase 1.
Phase 1 is the pre-inhepatic phase, also called the dissection phase. This is from surgical incision until the blood supply to the native liver is clamped off.
What are the big issues here?
Blood loss and massive fluid shifts. These surgeries often involve significant bleeding during the dissection of the diseased liver, which can be stuck down with adhesions. Also, when large volumes of a site's fluid are drained, it can suddenly unmask severe intravascular volume depletion. The patient was third spacing fluid, and now that pressure is gone.
And coagulopathy is baseline in these patients, right? Due to lack of clotting factor production by the liver.
Exactly. Coagulopathy management is paramount. Standard tests like PTINR are actually poor predictors of bleeding in ESLD. The gold standard here is thromboelastography, TEG, or rotational thromboelastometry, ROTEM.
How does TEG help?
It's a point-of-care test that gives a real-time picture of the entire clotting process, how quickly the clot forms, how strong it is, whether it's breaking down too fast, fibrinolysis. It shows you why the patient isn't clotting properly. Is it platelets, fibrinogen, clotting factors, excessive breakdown?
So you can target treatment precisely.
Exactly. Give platelets only if platelet function is poor. Give cryoprecipitate or fibrinogen concentrate if fibrinogen is low. Give antifibrinolytics like tranexamic acid if fibrinolysis is excessive. Goal-directed therapy based on TEG significantly reduces overall blood product transfusion compared to just chasing standard lab numbers.
What about CVP, central venous pressure? Usually we want it higher in bleeding.
Not here. Actually, the goal is often a low normal CVP during dissection. Lower venous pressure can help reduce bleeding from congested veins around the liver. We use 5% albumin primarily for volume resuscitation, avoiding large volumes of crystalloid which just leak out and worsen edema.
Any other metabolic issues in this phase?
Hypocalcemia is very common, especially if there's significant blood transfusion. Banked blood products contain citrate as an anticoagulant, and citrate binds calcium in the patient's blood. We often need continuous calcium infusions to maintain normal ionized calcium levels, which are crucial for heart muscle function.
Okay, phase 1 done. The clamps go on. Phase 2.
Phase 2, the anapatic phase. This is the period when the diseased liver is out and the new liver isn't in yet, or at least isn't reperfused. The patient has no functioning liver.
Metabolically, what does that mean?
Complete shutdown of hepatic metabolism. Lactate, which is normally cleared by the liver, rapidly accumulates, causing worsening metabolic acidosis.
And hemodynamically?
Often profound hypertension, especially if the surgeons use the traditional bicaval clamping technique, where both the inferior vena cava above and below the liver are clamped. This drastically reduces venous return to the heart. Preload just plummets. Newer piggyback techniques try to avoid clamping the cava fully.
So low blood pressure, rising acidosis.
Yeah.
What's the key anesthetic goal here?
Support the blood pressure, obviously, but critically, you need to aggressively treat the acidosis before reperfusion. Buff for the patient, often with sodium bicarbonate infusions, because you know the acidosis is about to get much worse in the next phase. Anticipation is key.
Okay, the new liver is sewn in, the clamps come off. Phase 3.
Phase 3, the neohepatic phase, or reperfusion. This starts the moment the clamps are released and blood flow is restored to the new liver graft. It's often the most dangerous few minutes of the entire operation.
Why so dangerous? What's the big fear?
The major concern is post-reperfusion syndrome, or PRS.
How is PRS defined?
It's defined as a sudden, dramatic drop in mean arterial pressure, MAP, usually more than 30% below the baseline MAP, lasting for at least 1 minute, occurring within the first 5 minutes after the clamps come off.
You described it as a toxic washout before. What exactly is hitting the systemic circulation?
When the portal vein clamp is released, all the fluid that was sitting in the cold preservation solution within the graft, plus blood that was stagnant in the portal system below the clamp, washes back into the heart. This reperfusit is cold, which can depress heart function. It's extremely acidic from anaerobic metabolism and the preservation solution itself. It's loaded with potassium that leaked out of the cold liver cells, causing potentially severe hyperkalemia, and it's full of inflammatory mediators released by the ischemic graft.
So it's a multi-pronged hit.
Yeah.
Cold, acid, potassium, inflammation.
Exactly. This toxic cocktail causes profound peripheral vasodilation, SVR crashes, and direct myocardial depression. Hence, the dramatic drop in blood pressure.
That sounds absolutely terrifying. How fast do you need to react?
Instantly, the team has to be poised. Management involves immediate, aggressive treatment with potent vasoconstrictors. Often high-dose boluses or infusions of vasopressin and epinephrine are needed right away to counteract the vasodilation and support the heart.
And what's the goal after stabilizing that initial shock?
Maintain adequate perfusion pressure to the new graft, obviously, but it's a balancing act. You need sufficient MAP, but you also want to avoid excessively high central venous pressure, CVP. High CVP causes venous congestion in the new liver, which can impair its function and even lead to early graft failure. So enough pressure, but not too much back pressure. It requires constant adjustment and often advanced hemodynamic monitoring.
Incredible complexity.
Yeah.
Let's shift now to the lungs. Lung transplantation. You mentioned this carries high risks, high mortality compared to others.
Yes, despite huge advances, it remains one of the highest-risk solid organ transplants. Perioperative mortality can be 20–30% in some series, and the complications, both immediate and long-term, are really significant.
What are the major hurdles post-transplants?
Two big ones really define the field. Acutely, the main complication is primary graft dysfunction, or PGD. This typically happens within the first 72 hours.
What does PGD look like?
It looks like acute lung injury, ALI, or full-blown ARDS, acute respiratory distress syndrome in the newly transplanted lung, severe hypoxemia, pulmonary edema on imaging, poor compliance. It often leads to prolonged mechanical ventilation and is a major driver of early mortality.
And the main long-term problem?
That's bronchiolitis obliterans syndrome, or BOS. This is a form of chronic rejection. It's a progressive, non-reversible scarring and obstruction of the small airways. The sources state it affects nearly 49% of lung transplant recipients within 5 years. It's the main limitation to long-term survival.
Allocation for lungs changed, didn't it? It's not just about waiting time anymore.
Correct. Since 2005, the U.S. uses the Lung Allocation Score, or LAS.
How does LAS work?
It's a complex score that tries to balance two things: the patient's risk of dying while waiting for a transplant and their predicted likelihood of surviving after the transplant, specifically for the first year. It gives higher priority to sicker patients who are likely to benefit most. It de-emphasized just sitting on the list for years.
And the criteria for even getting listed are pretty strict.
Very strict. Generally, the patient needs to have a risk of death from their lung disease greater than 50% within 2 years without a transplant, but also have a predicted likelihood of surviving at least 90 days after transplant greater than 80%. It's a tough window to hit.
And there are definite reasons someone would be turned down.
Yeah.
Contraindications.
Yes, several absolute and relative contraindications. Things like a body mass index, BMI over 35, active infections like tuberculosis, any malignancy within the last 2 years, sometimes longer depending on the cancer, uncorrectable severe coronary artery disease, or significant advanced dysfunction of another major organ like severe kidney or liver failure. The patient has to be sick enough to need the transplant, but well enough otherwise to survive the surgery and recovery.
Okay, into the OR for a lung transplant. These patients are often incredibly sick, coming in on short notice.
Very short notice, often less than 6 hours from offer to incision. Many are already critically ill, perhaps already on mechanical ventilation before surgery, which is a major risk factor.
Is there anything used to stabilize them before the OR?
Increasingly, yes. ECMO, extracorporeal membrane oxygenation, or ECLS, extracorporeal life support, is being used more and more as a bridge to transplant.
How does ECMO help?
It takes over the function of the lungs, and sometimes the heart. This allows the patient's native lungs to rest, potentially reduces ventilator injury, and crucially can allow the patient to be awake, participate in physical therapy, and maintain better muscle strength before the huge stress of surgery. It's really changing the game for the sickest patients.
Let's focus on anesthesia induction. You mentioned the central challenge is the risk of right ventricular, RV, failure. Why is the RV so vulnerable here?
It's the absolute core hemodynamic challenge. Many lung transplant candidates have pre-existing pulmonary hypertension because of their underlying lung disease. Their RV is already working hard, often enlarged and strained, pushing blood into those high-resistance pulmonary arteries.
And anesthesia makes it worse.
Potentially, yes. General anesthetic agents themselves can decrease cardiac contractility, and initiating positive pressure ventilation increases pressure in the chest, which further increases the resistance the RV has to pump against, pulmonary vascular resistance, or PVR. This combination can instantly tip a compensated RV into acute failure. It can dilate massively, stop pumping effectively, leading to cardiovascular collapse.
So induction requires extreme caution.
Extreme vigilance, often done very slowly, carefully titrating drugs. Continuous T-transesophageal echo is frequently used right from induction to watch the RV size and function in real time. You need to see trouble coming immediately.
So stabilizing hemodynamics means selectively helping the RV without dropping systemic pressure too much. What drugs are key?
You need standard vasopressors, ready phenylephrine for pure vasoconstriction, epinephrine or norepinephrine for pressure and contractility support. But the absolute agent of choice for targeting the RV's problem-high PVR is inhaled nitric oxide, INO.
Why INO?
Because when inhaled, it goes directly to the ventilated parts of the lung and acts as a potent, selective pulmonary vasodilator. It lowers the PVR, reducing the afterload on the RV, making its job easier. And critically, it does this with minimal effect on systemic blood pressure, unlike intravenous vasodilators, which would drop pressure everywhere. It's a vital tool.
Okay. Airway secured, hemodynamics hopefully stable. You need to operate on one lung while ventilating the other. How is that achieved?
Typically using a double-lumen endotracheal tube, DLT, which has two separate tubes allowing independent ventilation of each lung, or sometimes a bronchial blocker, which is essentially a balloon catheter placed down a regular ETT to block off one main bronchus. Left-sided DLTs are often preferred for anatomical reasons.
And the ventilation strategy for the remaining lung?
Very careful. The remaining native lung is often diseased itself. We usually employ a lung protective strategy. This often includes permissive hypercapnia, allowing the CO2 level to be a bit higher than normal, typically matching the patient's preoperative baseline to minimize ventilator pressures and volumes, reducing the risk of barotrauma or ventilator-induced lung injury.
What about PEEP? Positive end expiratory pressure, usually used in ARDS.
Needs extremely careful application. While some PEEP might be needed for oxygenation, too much PEEP or allowing dynamic hyperinflation, auto-PEEP, where the lung doesn't fully exhale, is incredibly dangerous.
Why is auto-PEEP so bad here?
Because severely hyperinflated lungs drastically increase pressure within the chest. This compresses the heart and great veins, severely impeding venous return to the right atrium and RV. It can cause a sudden catastrophic drop in cardiac output, mimicking cardiac tamponade. It's a killer. Vigilant monitoring of airway pressures and flow waveforms is essential.
And when you isolate one lung for surgery, what happens physiologically?
During one-lung ventilation, OLV, blood still flows through the non-ventilated collapsed lung. This creates a large intrapulmonary shunt blood bypassing gas exchange, leading to hypoxemia. Clamping the pulmonary artery to the surgical lung helps reduce the shunt. If the patient becomes too unstable, severe hypoxemia or hemodynamic collapse, during OLV, the team has to be ready to institute emergency cardiopulmonary bypass, CPB.
And after reperfusion of the new lung,
Yes.
still risk?
Yes, the risk of reperfusion injury, manifesting as PGD, is significant. This leads to that characteristic severe hypoxemia, pulmonary edema, and poor gas exchange within the first 24-72 hours. Because of this high risk of edema,
Fluid management.
the mantra for lung transplant teams is keep the patient dry. Fluid administration is severely restricted, especially crystalloids. The goal is to minimize any excess fluid that could leak into the new, potentially leaky lung graft and worsen edema or PGD. It's a very restrictive fluid strategy compared to other transplants.
Okay, we've covered the recipients in detail, but none of this happens without the donor? we need to shift focus to managing that other patient.
Absolutely critical. The success of every transplant we've discussed is fundamentally dependent on the meticulous management and optimal preservation of organ viability in the donor. The anesthetic care of the donor is a specialized field in itself.
Let's start with the most common scenario. Anesthetic care for the deceased donor, TBD, the brain-dead donor. What happens physiologically after brain death that makes management so challenging?
Brain death triggers a cascade of devastating physiological changes. Initially, there's often a massive sympathetic storm, a huge release of catecholamines causing hypertension and tachycardia. But this is followed by a complete loss of central autonomic control.
Leading to
Profound systemic instability, wild swings in blood pressure, often severe hypotension requiring vasopressors. Cardiac arrhythmias are common, neurogenic pulmonary edema can develop, disseminated intravascular coagulation, DIC, can occur, temperature regulation is lost, leading to hypothermia, and very frequently, diabetes insipidus, DI, develops.
Let's focus on DI. Why is that such a threat?
DI occurs because the pituitary gland, located at the base of the brain, stops releasing antidiuretic hormone, ADH, or vasopressin, after brain death. Without ADH, the kidneys can't reabsorb water.
So they just pour out urine?
Massive volumes of very dilute urine, sometimes liters per hour. This leads incredibly rapidly to severe dehydration, hypovolemia, and dangerously high sodium levels, hypernatremia, along with other electrolyte imbalances. This state is terrible for organ perfusion and viability.
How is DI managed in the donor?
Aggressively, requires meticulous monitoring of urine output and serum sodium. Massive fluid resuscitation is often needed, replacing urine output volume for volume, typically with hypotonic fluids. And ADH needs to be replaced, usually with infusions of vasopressin or DDAVP, titrated carefully to control the urine output and keep sodium levels in the normal range.
And the overall hemodynamic goal for the donor?
Maintain stability and optimal organ perfusion. The typical goal is a mean arterial pressure, MAP, between 60 and 100 millimeter Hg. Use fluids aggressively to maintain euvolemia, normal fluid balance. While vasopressors are often needed, the aim is to use the lowest effective doses, as high doses can sometimes compromise blood flow to specific organs. Donor management protocols are highly specialized and goal-directed.
And if we connect this to the bigger picture, the proper management of the donor is fundamentally intertwined with the recipient's success. Any period of hypotension or poor perfusion in the donor directly increases the risk of the organ not working well or failing completely in the recipient.
Precisely. That's why donor care is so critical. Every intervention, fluid choice, pressor selection, hormone replacement is done with the primary goal of preserving the optimal function of every single organ intended for procurement. It's about maximizing the gift of life.
What about the DCD donor donation after cardiac death? How does the anesthetic care differ there?
The process is very different and time-sensitive. The crucial step is the declaration of death based on circulatory criteria. This must be done by a physician completely independent of the transplant team.
How is death declared?
Based on the irreversible cessation of cardiac function, typically documented by the absence of a pulse, and more importantly, the absence of an arterial blood pressure waveform for a specified period, usually several minutes, after withdrawal of life support is initiated.
And once death is declared,
organ procurement must begin immediately to minimize warm ischemia time. Anesthesia and mechanical ventilation are only stopped after death is declared, and typically right as the surgical team cross-clamps the aorta and begins perfusing the organs with cold preservation solution to arrest metabolism.
finally, the living donor. These are generally healthy individuals undergoing major surgery for someone else's benefit.
Yes, typically much healthier than the deceased donors or recipients, but they are undergoing significant operations like a nephrectomy, kidney removal, or a partial hepatectomy, removing part of the liver. These are major abdominal surgeries with inherent risks, but no direct physical benefit to the donor themselves.
Which means the evaluation must be incredibly thorough.
Absolutely. Extensive medical evaluation to ensure they are truly low risk, but also rigorous psychological and ethical review to ensure they understand the risks and are donating voluntarily without coercion.
The big advantage from the organ's perspective.
Control. The surgery is scheduled electively, everything is optimized. And crucially, the cold ischemia time is minimal, often just minutes while the organ is moved across the operating room or between adjacent rooms. This translates almost directly into better immediate graft function and often better long-term outcomes for the recipient.
We have certainly taken a deep dive today. We've navigated the intricate landscape of 5 major solid organ transplants: kidney, pancreas, intestine, liver, and lung. We've unpacked the history, the allocation systems, and the absolutely critical, specialized role of anesthetic management in making these life-saving procedures possible.
It really highlights the evolution, doesn't it? From the initial surgical and immunological breakthroughs, like Carroll's techniques and the discovery of cyclosporine, to the current era where mastery of complex perioperative physiology, managing profound hemodynamic swings, metabolic chaos, coagulopathy is what truly allows these grafts and, more importantly, these patients to survive and thrive long term.
Absolutely. And the challenges continue.
Definitely. Continued efforts to increase organ availability through optimizing donor management, expanding DCD criteria safely, perhaps xenotransplantation down the line, and developing better, less toxic immunosuppression strategies remain absolutely vital for the future of the field.
And circling back to where we started, the stark supply versus demand issue. We highlighted how two massive public health problems, hypertension and diabetes, are the primary drivers pushing patients towards kidney failure, which leads to the most common transplant needed today.
Which brings us to a final provocative thought for you, the listener. We've spent this time talking about these incredible, high-tech, high-stakes medical interventions required after organs fail.
Like,
So the question is, considering these extraordinary advances in transplant technology, how might future medical strategies focused on aggressive preventative health, really getting serious about strict blood pressure control, tight glucose management, tackling obesity in the general population, how might that shift the fundamental dynamics? Could the greatest future innovation in transplantation actually be reducing the need for it in the first place? That's something to ponder.